The anterior tubercle with the anterior single moting ligaments, the posterior tubercle with posterior single moting ligaments. You see here, you can see three and four. From the front to the back, so you can understand that how this structure is small, tiny, this ankle with this talus and lateral malleolus, medial malleolus are congruent and doing particularly like a body like me, like you, all are doing, all are they are performing their day-to-day duties, these small tiny bones. Fortunately, we'll be discussing again and again with our biomechanics, with our different exercises there. You'll be getting also for the group discussions so that you can get the proper idea, and at least we can get the idea from our different faculties and other persons. So biomechanics of the subtalar joints have Harlan inversion, and the inversion is food is inverting, and that is called the supination combining with adduction and also the hindfoot produces external rotation of the talus causing a fracture of the distal fibula or a rupture of the lateral ligament. So the force is coming from the outside and then this pushing behind and also on the medial aspect. If talus rotation continues, the medial is above this and delta ligament major after initiating and that is totally and the force is going on and then force is on and on. So there's so many things and essentially the aversion side, oblique side. The important factor of major factors are they are intraarticular injuries. Naturally, they're always inside the joint. Soft procedure is very common as a bones are situated. Unilateral fractures are most common. There's only single bone fracture, single major fracture. Median malleolus or lateral malleolus, common is 68%. Bimalleolar fractures around 25%. Both lateral and medial malleolus. Bimalleolar fractures are little less, and the posterior malleolus is involved, that is totally around 7%. So the classification of the malleolar fractures, the most common malleolar fractures classification is the molar we should take because molar is the totally the other things. But it is basically the tennis and then the weber. This is the classification the AO has been taken. And then other classification like this at AO there are also some other classifications, particularly like Hansen, or we used to call it from since our student life, Loki Hansen. It's a very good classification, particularly in the cadaveric cadaver, while you can see the mechanism of injury is very much easy to deliver it, easy to see, easy to understand, but also very difficult to understand. Both. But yes, I should say, although easy is AO classification, but we also should try to understand because our faculties are here, so we can get some best ideas, the Logians and classification of that, the mechanism of injury, how the force is coming from the outside, how the force is coming from the inside, how the rotation is going on, one after another, is structures are failing. This is the beautifully has been described by Labaid. So based on the location of the fibula, the fractures are divided into three relations. There is your classification. That's again to the relationships of the level of syndesmotic ligament. Somebody says is the joint line. Well, we can, but I think in the syndesmotic attachment, this attachment of the ligament, that is why this tract above the syndesmosis is C type, along the line, horizontal line is B, and below it's A. So we can very easy to understand. Below A is A type at the level of the joint or in the molding line with B and above with C. So Logie Hansen is food, position of the foot is important here. Supination or pronation. It is supine, it is prone. So this is the thing. Supination, pronation. There is inversion, adduction, combined with this is supination. Pronation on the other hand, other side. So, and the ankle is in tension. The rotation of the talus is the main thing is the rotation. How the talus is rotating. It rotates medially straight way, or it is also rotating back and then devastating the other structures. So, supination adduction, supination external rotation, the A type, B, pronation, and pronation external rotation, abduction, and C1, C3. So, treatment indications, treatment indications for non-operative treatment, where to go non-operatively. As we in our country, many cases are coming late, neglected cases, neglected, and patients, what we are in a so remote place, we cannot perform this surgery, understanding the whole mechanism. All the implants are not available. Undisplaced, definitely. Stable fractures, and we can avoid. Clinically, no injury of medial ligament or ligament. Uh, So if we see that, to understand that there's no major injury, we can avoid. Patients with diabetes impairment, impaired circulation, particularly there are some, it's anesthetic foot, sharp foot ankle or sharp foot, then in that case, it is no way to go for surgical intervention. Unfit patients with limbs swollen, use this swollen, we should not. So X-ray control after 1 to 2 weeks or 3 weeks undertaken to check the stability. We can wait for 1 to 3 weeks and then we can check it, no hurry, and then you go for final decision. If I'm not an expert, I can refer it to other person. You fracture, or you can discuss it with the other person, with your friend. Today it's very easy to have knowledge. Even you can send X-ray with this to 5G in Malaysia or somewhere in India to get that knowledge, to get the idea what to do. So it's easy now. It was very difficult even 10 years back, 20 years back. For operative treatment, displaced fractures, unstable fractures, important condition is that the soft tissue is in a good condition, allowing your surgery. So you go on hurriedly and it will damage this because the skin is very vulnerable over here. Surgery involves open reduction and internal fixation by open reduction and internal fixation. So preoperative preparation is very important. Before the surgery, we have to think before everything. Many items must be prepared, check and recheck and recheck, check and recheck, and discussions on yourself, your team. On clinical examination, it is important to assess condition of the nerves and vessels because neurovascular, circulation, neurovascular position condition should be evaluated beforehand. And interfibula should be palpated, if possible. It's not very difficult. And see that whether there is the other injuries like Masonry, which is upper 1/3 of the fibula. And radiograph is important, apical view, lateral view, and also your motor view, which will be discussed later on. The 15 to 20 degree, just internally rotating the foot. Timing of surgery depends on the patient comorbidities like diabetes, other things, lot of heart problems, this problem, that problem. So all this has to be considered. Soft tissue status, as I told you earlier, and this is important. Key success for your condition. No hurriness here. You have to be very particular in that case. Displaced ankle fracture, when it comes to you, you have to be reduced it as early as possible and splinted it with backslap, which is available everywhere. because of the delicate soft tissue cover over the two malleoli. The timing of surgery is crucial to avoid compromised healing. If the ankle is very swollen and the skin looks like an orange spill, you can see it here, orange spill, then and blisters are there, definitely surgery should be postponed. Where a lot of lectures will be here and discussions will be here. So options are spanning with external fixators, and you can go for external fixators. We're available now everywhere in the rural areas when the spanning is available. Position the patient, patient will be supine position, putting one pillow over that particular heap so that the it will be raised and you can have a good support over the ankle and then this on the butt of this sandbag should be on the bottom and you can have a good posterolateral and lateral access. The four-figure position, if you are a floor position, for good median and posterior access. I don't know this. They can tell you more details. And correct position is important. আমরা ভুল পেশেন্টকে অপারেশন করে পেপারে উঠাতে চাই না আমরা সাইড ডান সাইডটা বাম সাইডে করতে চাই না রাইট সাইড রাইট অ্যান্ড দেন রাইট পজিশন অলসো কোথায় অপারেশন করবো দ্যাট ইজ অলসো ইম্পর্টেন্ট এটিও আমাদের খেয়াল রাখতে হবে sequence of fixations প্রথমে usually as because we have got this supination and pronation type of injury those injuries are so there is syndromotic damage. So in that case, it's better to sequentiate it from the lateral side to the medial side. Lateral malleolus from the, and then it comes from the lateral to medially. It will be discussed again later on. Here you see this a little bit about the medial malleolus. The if we the anterior auriculus, posterior, this is a small portion I tried to show you. And then lateral malleolus, the approach, reduction, fixation, all from the straight lateral incision for the lateral malleolus, medial approach, straight medial approach for the medial fixation, medial malleolus fixation. So fixation by plate, screw, and then tension band writing for lateral malleolus. Usually we go for plate for the lateral malleolus because we need to stabilize more. A little bit longer plate is needed here, and most of the time because this failure of the syndesmosis may occur or usually occurs. So we have to be cautious. After care, apply a slap to the lower leg with foot in neutral position. Start physiotherapy. Start physiotherapy. As early as on the day one, this is very important. We put the plaster again. গলায় চড়িয়া মধ্য হাঁটিয়া চলিল এ কথায় শামসুদ্দিন স্যার খুব বলতেন আমরা অপারেশন করলাম সুন্দর প্লাস্টার করে দিলাম পর 3 মাস তাহলে আমাদের আলটিমেটলি আমাদের রেজাল্ট হচ্ছে 0 so day one physiotherapy if you if I want my way to doing it at least for stitch removal so I can put a little bit a back slap for 10 days and then remove the plasters and remove everything and start mobilizing immediately. But there, people are telling that you go for day one physiotherapy, that is applying crepe bandage, elevate the limb, and then start mobilizing, and then very little, allow immediate partial weight bearing, 10 to 15 kg, I mean toe touch. That is also important. So case one, this is a case you see how the fixation is done. There median malleolus and above the ankle fracture. So case two, another case totally trimalleolar fracture. So from the back also has been applied. This is the tension band wiring on the lateral side and medial side only single screw. So there are a lot of discussions will be. So in a humble way, I'm just talking to you. And so our faculties will be delivered more elaborately and they will be talking about our whole day, these 2 seminars. So take a message yourself and take care of the soft tissues, understand the mechanism of injury. This is very important. And mechanism of injury is so important. You have to understand it, how the force was coming and how it happened. So our management accordingly always seek anatomical reduction because this is a joint and we have to achieve the 100% or 99.9% congruity. Be aware of the potential for syndesmosis injury, identify and treat it appropriately. We have to always think that syndesmotic injury is there. We discard it, well, if it is not there, we are lucky. But if there is syndesmotic injury, then there will be a mess if we do not address it properly. Thank you very much.
May I ask you a single question? 2 questions.
Question hour is there. I think that question hour common hour.
Discussion will be later after lecture.
As a boy question করো না এখন তো বন্ধ হওয়ার পরে কোশ্চেন অবশ্যই কোশ্চেন করতে হবে কোশ্চেন কিন্তু করতে হবে we want that question